Imagine for a second that your body is a modern, high-tech aircraft.
Okay.
The conscious you're the pilot. You're grabbing the stick, you're deciding to turn left, climb to 30,000 feet, maybe radio the tower.
That's your somatic nervous system. It's all voluntary.
Exactly. It's what you decide to do. But, I mean, a pilot isn't manually pumping fuel to the engines or adjusting the cabin pressure valve by valve.
No, of course not. There's this huge, complex autopilot system running everything in the background.
That's it. That's the autonomic nervous system.
Yeah.
And specifically today, we're looking at just one branch of it, the rest and digest branch.
The parasympathetic system.
But here's the thing, the misconception we need to just shatter right at the top.
Oh, I think I know where you're going with this.
People often think rest and digest is just an off switch. You know, you flip a toggle, the body relaxes, and you go to sleep.
And it's not that simple, not even close.
No. Digging into the source material for this deep dive, it became immediately obvious that that's completely wrong. It's not a switch.
It's a mixing board.
It's a massive sound engineering console with thousands of dials. You can turn up the secretions in the stomach while turning down the heart rate.
Or squeeze the bladder muscle but relax the sphincter valve right next to it. It's an incredible level of fine-tuning.
It's precision engineering.
Yeah.
And that entire mixing board is controlled by a single master key, acetylcholine.
But, and this is the important part, it's controlled by the specific receivers that acetylcholine talks to, the muscarinic receptors.
And that is our mission today.
Mm.
We're doing a deep dive into muscarinic signaling. We're going to look at how we can turn these dials up and how we can turn them down to treat everything from glaucoma to COPD to poisoning.
And to do this, we are synthesizing two absolute titans of pharmacological literature. We have Katzung's Basic and Clinical Pharmacology, which is essentially our field manual.
Mm-hmm.
It gives us the clinical scaffolding, the organization.
It tells you what happens in the patient.
Exactly. And we are pairing that with Goodman and Gilman's The Pharmacological Basis of Therapeutics, the Blue Bible.
Which gives us that incredible molecular depth, the why behind it all.
The systems level insight. So you get the practical guide and the molecular blueprint.
I like that.
Precisely. But I need to make a very, very important disclaimer right at the top here.
Okay.
What you are hearing today is an interpretive synthesis. It is a conceptual map we've built to help you navigate these dense topics. It is absolutely not a substitute for the textbooks.
Right. We want you to use this audio as a scaffold.
Yes. But you need to actively read Katzung Chapter 7 and 8 and Goodman and Gilman Chapter 9. That is where the real mastery happens.
Consider us the tour guides, but you still have to hike the trail yourself.
Perfect analogy.
So before we get into the weeds, and we're literally going to talk about weeds like Jimson weed later, let's give everyone listening a roadmap. What are the big 5 concepts we're locking in today?
Okay, if you take nothing else away from this, focus on these 5 pillars. First is receptors as modulators.
Okay.
We need to understand how we have 5 different subtypes of muscarinic receptors, M1 through M5, and how they translate the exact same molecule, acetylcholine, into totally different effects.
So it's like how the same electrical signal can make a speaker blast heavy metal or a light bulb glow softly.
That's a great way to put it. Same input, different machinery. Second is context dependence.
This one is fascinating.
It really is. We'll learn why the same drug can relax a blood vessel or constrict it, depending entirely on the integrity of the tissue, specifically whether the lining, the endothelium, is intact.
That's the rubbed versus unrubbed experiment. That blew my mind when I first read it in Katzung.
It's a crucial lesson in physiology. Third is the dial settings.
Meaning?
We need to appreciate that different organs, the eye, the heart, the gut, the lungs, have different sensitivities to these drugs. It's not a uniform response across the whole body.
Oh, okay. What's number 4?
Fourth is that mechanism predicts toxicity. When things go wrong, when a patient gets poisoned or overdoses, it's not random bad luck. It's a predictable, logical extension of the drug's primary mechanism.
And this is where we get into why an overdose of one drug makes you wet and another makes you dry.
Exactly. And finally, number 5 is clinical reasoning.
The ultimate goal.
The goal. We want to move you beyond just memorizing drug names. We want to get to a place where you can choose a drug based on the specific system effect you need to achieve.
Treating urinary retention versus treating glaucoma, for instance.
Right. It's about thinking through the problem from the mechanism up.
Okay, that's a fantastic roadmap. So let's get into it. Section 1, the molecular machinery, the why and the how.
Let's start with the neurotransmitter itself. Acetylcholine, it's the natural ligand, right? It's what your body uses.
Yep. the original key.
So here's a question. If a patient has a lazy bladder or maybe a heart rate that's too fast, why don't we just, inject them with acetylcholine?
It seems like the obvious solution, doesn't it? If you're low on gas, add gas.
It does.
But Goodman and Gilman is pretty savage about this. I think the quote is it has virtually no systemic therapeutic applications.
It's practically useless as a drug. Why is that? What are the problems?
Well, digging into the text, there seem to be two huge reasons. First, it's just too diffuse. It acts everywhere.
It's not selective at all.
No, it hits every muscarinic receptor, but it also hits all the nicotinic receptors in the ganglia and on skeletal muscle. It's like trying to water a single flower pot by turning on the fire hydrants for the whole street.
You'd get effects in the brain, the muscles, the ganglia, the heart, the glands. It would just be a mess, a total systemic chaos.
Okay, so that's problem one. What's the second reason?
Speed.
It's destroyed almost instantly. We have this enzyme, acetylcholinesterase, or ACE, that's incredibly efficient at the synapse. It's just waiting to chew it up.
It has one of the highest catalytic rates of any enzyme in the body. It is brutally effective.
And Goodman and Gilman also highlights that it's not just at the synapse. There's also plasma butyrylcholinesterase floating around in the blood.
Right, sometimes called pseudocholinesterase.
So even if you injected ACE intravenously, it would be degraded before it even got to most of the target tissues. It's a race it can't win.
Exactly. So pharmacology had to solve this problem. We needed imposters.
Right. We needed drugs that look enough like acetylcholine to ring the doorbell.
But are built tough enough to survive the enzymes. And that gives us two families of drugs. We have the synthetic congeners, like bothanicol.
Which is basically a modified, tougher version of acetylcholine.
And then we have things we just found in nature, alkaloids that just happen to fit the lock, like muscarine for mushrooms, which is where the receptor gets its name.
Which leads us to the lock itself, the muscarinic receptor. I really appreciated the visual description in Katzung. It calls it a serpentine structure.
Yes, the classic G-protein coupled receptor, a GPCR. You have to picture a single protein chain that weaves back and forth in and out of the cell membrane 7 times.
Like a snake sunning itself on a wall.
A perfect image. Now, visualize this. Deep inside that bundle of coils, buried within the fatty part of the membrane, is the binding site, the place the key actually fits.
And Goodman and Gilman describes this beautifully. It talks about a lid made of tyrosine molecules.
Yes.
It separates the outside world, the sort of outer vestibule, from this deep inner sanctum where the action happens.
And that deep inner sanctum is called the orthosteric site. That's where acetylcholine binds. But here is the challenge for drug designers, and this is a central theme.
Go on.
That deep pocket, the orthosteric site, is highly conserved across the subtypes.
Meaning it looks almost identical in an M1 receptor in the brain, an M2 receptor in the heart, and an M3 receptor in the bladder.
Exactly the same. It's like a car company using the exact same ignition lock for their sedans, their sports cars, and their pickup trucks.
So it's really, really hard to design a key that only starts the truck, but not the sedan.
That is the core problem of muscarinic pharmacology. It's why we have so many side effects. Most of our classical drugs are somewhat dirty, as we say. They hit multiple subtypes because the lock looks the same everywhere.
But you mentioned the vestibule, the area above the lid.
Right. And Goodman and Gilman points out that this area, this allosteric site, is much more variable between the M1, M2, and M3 receptors.
And that's the future, isn't it? Targeting that instead of the main keyhole.
We'll touch on that at the very end, but yes, if we can target the vestibule, we can get the specificity we've always wanted. But for now, for the drugs we use every day, we have to deal with the classic signaling.
Okay, so let's talk about that signaling. We generally split these receptors into 2 teams based on what happens after the key turns.
The G-protein coupling.
In my notes, I've been calling them the squeezers and the inhibitors.
That's actually quite accurate. I like that. Let's look at team 1, the odd numbers. M1, M3, and M5.
The squeezers.
These are coupled to the GQ protein. And when you see GQ, you should immediately think calcium.
Right. It's all about mobilization. So walk me through that cascade again. The receptor fires.
It activates GQ. GQ then turns on an enzyme in the membrane called phospholipase C.
And that enzyme acts like a pair of scissors. It cuts a membrane lipid, PIP2, into 2 smaller messengers.
IP3 and DAG3.
Inositol trisphosphate and diacylglycerol.
And IP3 is the real messenger here, right? It diffuses away from the membrane. It does. It goes to the sarcoplasmic reticulum, which is basically the cell's internal calcium vault, and it binds to a channel there and unlocks it.
Boom. massive release of calcium from storage into the cytoplasm of the cell.
And what does a flood of intracellular calcium do?
It causes contraction in smooth muscle or secretion in glands.
So when an M3 receptor fires in your gut, it squeezes. When M3 fires in your salivary glands, you drool. Squeezers. It works.
Okay, that's team 1. Then we have team 2, the Eden numbers, M2 and M4.
The inhibitors.
They are coupled to G or GO, and the I stands for inhibitory.
Right. So instead of a calcium party, they shut things down.
Yeah.
The main mechanism is that they inhibit an enzyme called adenyl cyclase.
Which means you make less cyclic AMP or CAMP.
Yeah.
You're lowering the level of this really important activating signal.
But Katzing emphasizes something else here, too, something incredibly important for the heart. It's not just about CAMP.
Potassium.
It's about potassium. The beta-gamma subunits of that inhibitory G protein break off, and they go and physically pop open potassium channels.
And when potassium channels open, potassium, which has a positive charge, rushes out of the cell down its concentration gradient.
And as all that positive charge leaves, what happens to the inside of the cell?
It becomes more negative. It hyperpolarizes.
Exactly. It moves further away from the voltage threshold it needs to fire an action potential. It becomes harder to excite. This is essentially how the vagus nerve acts as a brake pedal on the heart.
Making the hill steeper to climb for the next beat.
A perfect summary. So we have the machinery. Squeezers, the odd numbers, use calcium to contract and secrete. Inhibitors, the even numbers, use low AMP and open potassium channels to slow things down.
Okay, now that we have the engine parts laid out on the table, let's see what happens when we step on the gas. Section 2, turning it up. Agonists and physiology.
And we have to start with the cardiovascular system. We just have to, because it presents a paradox that really, really confuses students.
The cardiovascular paradox. Okay, let me set the scene based on the text.
Yeah.
If I inject a muscarinic agonist, like a shot of acetylcholine, into a person, their blood pressure plummets. They get massive vasodilation.
Correct. A profound drop in blood pressure.
But if you look at the anatomy books, most blood vessels, especially the small resistance arterioles that actually determine blood pressure, don't have any parasympathetic nerves hooked up to them.
The vast majority of the vasculature has no cholinergic innervation. It's almost entirely controlled by the sympathetic system.
So we have a drug causing a massive effect on a tissue that shouldn't even know the drug exists, evolutionarily speaking. So what is going on? Is this just a weird quirk?
This leads us to the classic, beautiful experiment described in Katzung. It perfectly illustrates this idea of context dependence.
Okay, lay it out for us.
Imagine you have an isolated strip of a blood vessel, maybe an aorta, in a petri dish. You add acetylcholine to the bath.
And it relaxes. It vasodilates.
It relaxes. Now you take a little wire or a swab and you gently, very gently, rub the inside of that vessel strip. You are scraping off the inner lining, the single layer of endothelial cells.
Okay, so you've damaged the inner wall.
You've denuded it. Now you add the exact same dose of acetylcholine again. What happens?
It constricts. It does the exact opposite thing.
Well, polar opposite. Why?
This is the unrubbed versus rubbed experiment. And it all comes down to where the M3 receptors are. In the healthy vessel, the unrubbed one, the acetylcholine in the blood hits M3 receptors on the endothelial cells.
The lining cells, not the muscle cells.
Right. And those endothelial cells, being M3, run that GQ pathway we talked about. They get a burst of calcium.
And what do the endothelial cells do with that calcium?
They activate an enzyme called ENOS endothelial nitric oxide synthase. They use it to manufacture nitric oxide gas.
And nitric oxide is like a ghost. It's a tiny, uncharged gas molecule. It just diffuses right out of the endothelial cell and into the smooth muscle cell right next door.
And it tells that muscle cell to relax. It's an indirect message.
A beautiful indirect paracrine signal. But when you rub the vessel,
You remove the middleman. You scrape off the endothelium. Now there's nothing between the drug and the muscle.
exactly. Now the acetylcholine hits the M3 receptors that are sitting directly on the smooth muscle itself.
And M3 is a squeezer. It releases calcium in the muscle and boom, vasoconstriction.
That is wild, isn't it? The effect of the drug depends entirely on the health, the physical integrity of that single layer of cells.
So what does this mean for a patient?
It means if a patient has severe atherosclerosis or endothelial damage, a muscarinic agonist might not vasodilate as well as you expect. In some damaged areas, it might even cause a paradoxical constriction. Context is everything.
Okay, let's move from the vessels to the pump itself, the heart, the brake pedal.
Here, we are almost exclusively talking about the M2 receptor, the inhibitor. It's found in high density right on the SA node, the pacemaker, and the AV node, the gatekeeper.
And like we said, M2 is an inhibitor. It opens those potassium channels, letting positive charge leak out, making the cell hyperpolarize and harder to fire.
It slows the rate of diastolic depolarization. It flattens out that pacemaker potential.
So it slows the heart rate.
Yeah.
That's a negative chronotropic effect. And it slows conduction through the AV node, a negative dromotropic effect.
Precisely. But Goodman and Gilman goes even deeper here. It mentions that besides just membrane voltage, ACE inhibits the funny current, the AFib current that helps initiate the pacemaker potential.
But I also saw a mention of something called the calcium clock theory.
Yes, this is a more modern concept. It suggests that acetylcholine isn't just messing with the ion channels on the membrane. It might actually be regulating an internal rhythmic release of calcium inside the pacemaker cell that helps set the pace.
So it's almost like slowing down the internal metronome of the cell, not just muting the volume at the membrane.
It's a fascinating area of research, but for clinical purposes, the big takeaway is muscarinic agonists slow the heart, bradycardia.
Except sometimes they speed it up. There's a caveat here too, isn't there?
The reflex, yes. This is where you have to look at the whole body, not just the isolated heart. If you inject a small dose of a potent agonist,
The blood pressure drops so fast because of that vasodilation we just talked about.
that the body panics. The baroreceptors in your aorta and carotid arteries scream, "Emergency! Low pressure!" And the sympathetic nervous system kicks in with a massive counterattack to compensate.
So the brain's panic signal overrides the drug's direct effect on the heart.
For a moment, yes. You might see a brief reflex tachycardia before the direct bradycardia from the M2 stimulation takes over. Context matters. You always have to ask, is this a direct effect or a reflex?
Okay, let's leave the heart and go to the squeezers.
Yeah.
The eye, the gut, and the bladder. This is where we see the most common clinical uses for muscarinic agonists.
Absolutely. Let's start with the eye. We're talking M3 receptors on two different
The
muscles.
sphincter of the iris.
Stimulation there causes it to contract. The pupil shrinks. We call that meiosis. Pinpoint pupils.
And the other muscle.
The ciliary muscle, and this is more important for therapy.
When the ciliary muscle contracts, it does two things. It changes the shape of the lens to allow you to focus on near objects. That's accommodation.
But it also, through a bit of anatomical geometry, pulls on the trabecular meshwork at the base of the cornea.
The canal is Schlemm. It opens the drain.
It pulls the drain open. That allows the aqueous humor, the fluid inside the front of your eye, to flow out more easily. This lowers the pressure inside the eye.
And that is why a drug like pilocarpine is used for glaucoma.
Exactly. It's basically plumbing. If the sink is overflowing and the pressure is building up, you use a drug to physically pull the drain open.
And the same plumbing logic applies to the gut and bladder. It's the rest and digest system, so it's all about movement and emptying.
Right. If the gut is lazy, a condition we call postoperative ileus, where the bowels just don't wake up after surgery, or if the bladder won't empty, a condition called urinary retention.
We need to squeeze them.
We need to squeeze them, and the classic drug for this is bethanechol.
Right. Bethanechol is a sturdy synthetic agonist. It's designed to resist being broken down by cholinesterases. It hits those M3 receptors and forces the bladder wall, the detrusor muscle, to contract.
While also helping to relax the trigone and sphincter muscles, coordinating the whole process of urination.
But here is a key chemical distinction I want to highlight from the notes because it's so important for side effects. Bethanechol is a choline ester. It's a quaternary amine.
Quaternary is a word we're going to hear a lot. It just means the nitrogen atom in the molecule has 4 chemical bonds instead of the usual 3. This gives it a permanent positive charge.
And because it's charged, it's polar, it loves water, it hates fat.
And the blood-brain barrier is, for all intents and purposes, a wall of fat.
So bethanechol just bounces right off it. It can't get into the central nervous system.
Which is great. That's a feature, not a bug. If you just want to empty the bladder, the last thing you want is a drug stimulating M1 receptors in the brain and causing tremors, confusion, or seizures.
You want the drug to stay in the body bucket, not get into the brain bucket?
A perfect way to think about it. The charge keeps it confined to the periphery.
Okay, so that covers the direct agonists, the drugs that mimic acetylcholine. But there is a whole other class of drugs that are sneakier, the amplifiers.
The indirect agonists, or more accurately, the acetylcholinesterase inhibitors.
Right, so instead of doing the job themselves, they just fire the janitor. They inhibit the enzyme that breaks down acetylcholine.
So your own natural, endogenously released acetylcholine, survives for longer in the synapse, its concentration builds up, and it hits the receptors harder and for a longer time.
You're amplifying the body's own signal.
Exactly.
Mhm.
And we classify these based on how long they last and, again, whether they can get into the brain.
The short-acting one is edrophonium. It's
Mhm.
essentially a diagnostic tool, right?
Yes, exactly. It binds very briefly and reversibly to the enzyme. We used to use it for what was called the tensilon test to diagnose myasthenia gravis.
Myasthenia gravis being the autoimmune disease where your antibodies are attacking your nicotinic receptors on your muscles, causing weakness.
Right. So you'd give the patient a shot of edrophonium. It boosts the AC8 at the neuromuscular junction for just a few minutes. If the patient's weakness suddenly and dramatically improved, you knew it was myasthenia.
Okay, then we have the medium duration therapeutic ones. The main pair here is neostigmine and physostigmine. And this is where that quaternary versus tertiary amine chemistry comes back with a vengeance.
Neostigmine is quaternary. It's charged. It stays in the periphery.
So it's perfect for treating myasthenia gravis long-term because that's a muscle problem, or for getting the gut moving because that's a peripheral problem.
Exactly. You don't want it in the brain. Physostigmine, on the other hand, is a tertiary amine. It's uncharged at physiological pH. It's lipid-soluble. It's a ninja.
It slips right through the blood-brain barrier.
And that is precisely why physostigmine is the antidote for atropine poisoning. Atropine is an antagonist that gets into the brain and causes delirium. You need an antidote that can follow it in there and reverse the effect. Neostigmine can't do that.
It's locked out.
It's locked out. Then we have the scary group, the really long-acting ones.
The organophosphates.
These form a very stable, covalent bond with the enzyme. For all practical purposes, it's irreversible. We do use one, ecothiopate, as eye drops for very resistant glaucoma.
But mostly, these are known as insecticides, like malathion and chemical warfare agents, nerve gases, like sarin.
We'll get to the toxicity of those in a bit because that is a whole survival horror movie on its own.
Okay, but before we leave the amplifiers, we have to mention Alzheimer's disease.
Yes, a very important application. In Alzheimer's, we know there's a progressive loss of cholinergic neurons originating in the basal forebrain. These neurons are critical for memory and cognition.
And the M1 receptors in the cortex and hippocampus are deeply involved in those cognitive processes.
So the strategy is to use lipid-soluble cholinesterase inhibitors, drugs like donepezil, rivastigmine, galantamine, that can cross the blood-brain barrier.
And the goal is to boost whatever acetylcholine is left in the brain to amplify the remaining signal and hopefully preserve cognitive function for a bit longer.
Exactly. It's not a cure. It doesn't stop the neurodegeneration, but it turns up the volume on the signal that's left.
All right, let's turn the dials up now. Let's flip the script. Section 3, turning it down, the antagonists.
And the prototype here, the original gangster of muscarinic antagonists, is atropine. It comes from the plant Atropa belladonna deadly nightshade.
And belladonna means beautiful lady in Italian.
It does, because back in the Renaissance, women would put drops of the plant extract in their eyes to dilate their pupils. They thought it made them look more alluring.
I suppose it just made them look very surprised and unable to read anything up close.
And very photophobic, yes. But mechanistically, atropine is a pure competitive antagonist. It sits in the lock, the orthosteric site of the receptor, but it doesn't turn the key. It just physically prevents acetylcholine from getting in and doing its job.
Now, Katzing has this fantastic table, table 8.2, that I think is vital. It lists the effects of atropine by dose, and it's not all at once. There is a very clear hierarchy.
It's incredibly consistent and clinically important. As you slowly increase the dose of atropine or any non-selective antagonist, the very first thing to go is the glands, the most sensitive tissues.
So, dry mouth, xerostomia, and decreased sweating.
Correct. That's the low-dose effect. Then, as you give a little more, you start to hit the eye and the heart.
The pupils dilate mydriasis. Vision gets blurry because you can't contract the ciliary muscle to accommodate for near vision. And the heart rate speeds up, tachycardia, because you're blocking the vagal brake.
Then higher still.
Then you start hitting the smooth muscle of the gut and bladder. Peristalsis slows down, leading to constipation, and the bladder wall relaxes, causing urinary retention.
And finally, at the very highest doses.
Gastric secretion. You finally inhibit the acid production in the stomach.
And this hierarchy perfectly explains why we don't use atropine for peptic ulcers anymore.
Right, because think about it. To give enough atropine to stop the acid, which is step 4 on the list,
you have to drag the patient through dry mouth, blurred vision, tachycardia, and constipation first. The side effects are not just possible, they are guaranteed.
that's a terrible user experience. Congratulations, your ulcer is gone, but now you can't see, spit, pee, or poop.
Precisely. That's why we develop drugs like proton pump inhibitors. They are incredibly specific to the acid pump in the stomach. Atropine is just too blunt a tool for that job.
Now, there's a weird little blip in the heart rate data with atropine that I found in both sources. We said atropine blocks the vagus nerve, so it should speed up the heart. But at very, very low doses, it sometimes slows it down first.
The paradoxical bradycardia, this is a classic exam question, and it brings us back to those M1 receptors.
The autoreceptors.
Yes. On the vagus nerve terminal itself, right before the synapse, there are M1 autoreceptors. Their job is negative feedback. When they sense that ASHI has been released, they send a signal back to the nerve saying, okay, that's enough, stop releasing so much.
So they are on the brake pedal.
A perfect description. Now, if you give a tiny, tiny dose of atropine, it's thought that it might be just enough to block these highly sensitive presynaptic M1 autoreceptors before it gets to a high enough concentration to block the main M2 receptors on the heart muscle itself.
So you cut the brake line on the brake pedal.
In a sense,
Yeah.
you block the negative feedback loop. The nerve terminal thinks, hey, I'm not releasing any AXIDO, so it panics and dumps more AXAT into the synapse.
And that transient flood of extra ASAT briefly overcomes the low-level blockade on the heart, causing a temporary slowing.
But then as the dose of atropine increases,
It floods the synapse and blocks the postsynaptic M2 receptors on the heart itself. The brake is fully released, and you get the expected tachycardia.
exactly, it's a neat piece of pharmacology.
Okay. Now, just like with agonists, we have specific antagonists for specific problems. We don't just use atropine for everything. We've gotten smarter.
Thank goodness. Take the lungs. In COPD or asthma, the airways are constricted and there's a lot of mucus. A big part of that is driven by parasympathetic vagal tone.
So we want to block that. But we don't want to block the heart or the bladder if we can help it.
Right. So we use drugs like ipratropium or tiotropium. And again, chemistry is king. These are quaternary means.
They're charged, so you put them in an inhaler.
You inhale them as an aerosol. Because they are charged, they don't get absorbed from the lungs into the bloodstream very well. They stay local.
They stay in the lungs where the problem is. They block the M3 receptors on the bronchial smooth muscle to stop bronchoconstriction and on the glands to dry up secretions. But they don't give you significant dry mouth or tachycardia system-wide.
It's brilliant drug design. Keep the drug where you need it.
What about the bladder? For overactive bladder, or OAB?
For OAD, the problem is the decrussor muscle is contracting when it shouldn't, so we want to relax it. We use M3 antagonists like oxybutynin.
But oxybutynin is kind of notorious for side effects, isn't it? I've heard patients complain constantly about the cotton mouth and feeling foggy.
It is. It's not very M3 selective. It hits M3 in the bladder, which is what you want, but it also happily hits M3 in the salivary glands, causing dry mouth. And because it's lipid-soluble, it crosses the blood-brain barrier and blocks M1 receptors, causing confusion and sedation, especially in the elderly.
So the newer drugs, like darafenacin or sulfenacin,
They try to be more M3 selective. The goal of the drug companies was to design a molecule that fits the M3 receptor better than the M1 or M2 receptors to reduce those cognitive and cardiac side effects.
and how successful have they been?
They're better, but still not perfect. The selectivity is relative, not absolute, but it's a step in the right direction.
Okay, we've tuned it up, we've tuned it down. Now let's talk about what happens when the mixing board completely catches fire. Section 4. When systems fail. Toxicity and poisoning.
Let's start with the wet crisis, an overdose of agonists, or more commonly, cholinesterase inhibitors.
This could be someone eating the wrong kind of mushroom, like an inocybe species that's full of muscarine.
Or, far more likely in the clinic, a farmer getting exposed to organophosphate pesticides or a victim of a nerve gas attack. The symptoms are simply a grotesque exaggeration of the parasympathetic system. Everything that can be on is stuck in the on position. Everything flows.
And the mnemonic found in every medical textbook is Dummadale S.
Or sometimes Sulligy Bam. They all describe the same horrifying picture. Let's walk through Dumbbell S.
D is for diarrhea. U is for urination.
Total loss of bowel and bladder control.
M is for meiosis. The pupils constrict down to tiny pinpoints.
B is for bronchospasm, the airways clamp shut, and bronchorea, the lungs fill with fluid.
So you can't breathe.
You can't breathe, and you're drowning in your own secretions. The second B is for bradycardia. The heart slows down until it starves.
E is for emesis, or vomiting. L is for lacrimation, tears streaming down. S is for salivation, profuse drooling. And the final S is for sweating.
It's essentially a total loss of bodily containment. The patient is leaking from every orifice, their heart is stopping, and they can't breathe. It's a profound medical emergency.
The treatment, logically, has to be a powerful antagonist.
Atropine. Massive doses of atropine. You need to block those overwhelmed muscarinic receptors immediately to dry up the secretions, open the airways, and get the heart rate back up.
But with nerve gas, with the organophosphates, there is a ticking clock involved, a literal timer on the molecular bond itself.
This is a critical concept specific to organophosphates. They bind to the active site of the acetylcholinesterase enzyme, forming a covalent bond.
So it's not just sitting there, it's chemically bonded.
Right. And initially that bond is, in theory, reversible. But over time, we're talking minutes to hours, depending on the specific chemical. The molecule undergoes a process called aging.
Aging. What is happening chemically during aging?
The organophosphate molecule loses an alkyl group. A piece of itself breaks off. And once that happens, the remaining chemical bond to the enzyme rearranges and becomes incredibly stable. It becomes permanent.
It's like superglue that takes an hour to fully harden.
That's a great analogy. Before it hardens, you might be able to wipe it off. After it hardens, you can't. The enzyme is dead. You have to wait for the body to synthesize brand new enzyme molecules, which can take weeks.
So you have to intervene before it ages. You have to get the poison off the enzyme.
Correct. And the drug for that is an enzyme reactivator. The classic one is pralidoxim, also called 2PM.
In my head, I call pralidoxim the crowbar.
That's a good image. It has a chemical group that is strongly attracted to the phosphorus atom of the organophosphate. It wedges itself in and chemically pries the organophosphate off the enzyme, regenerating it. But, and this is the key point, it only works before aging occurs.
Once the superglue is hardened, the crowbar won't fit. It's too late.
Exactly. And there's another catch with pralidoxim, too. It's a quaternary amine.
So it has a positive charge, which means
it doesn't cross the blood-brain barrier.
So if you are poisoned with sarin nerve gas, pralidoxim will rescue the cholinesterase on your diaphragm so you can breathe again, which is in the periphery.
But it won't do anything to stop the seizures and respiratory depression happening in your central nervous system.
So you need both. You need atropine to block the symptoms everywhere, in the brain and the body, and you need pralidoxim to save the enzymes in the body before they age out.
That is the standard of care. Atropine plus an oxime reactivator.
Okay, now let's flip it one last time. The dry crisis. Antagonist overdose. Atropine poisoning.
Or, as we see sometimes, Jimson weed ingestion. Teenagers might hear about it online and eat the seeds to get a hallucinogenic high, not realizing they are taking a massive, uncontrolled dose of atropine-like alkaloids.
And the mnemonic for this is straight out of a demented nursery rhyme.
Dry as a bone.
No sweating, no saliva, the mouth is like sandpaper.
Blind as a bat.
The pupils are huge, you can't focus on anything.
Extreme light sensitivity.
Red as a beet.
Flushing, especially of the face and upper torso. This is due to cutaneous vasodilation as the body tries to dump heat since it can't sweat.
Hot as the hair.
Hyperthermia. The inability to sweat can lead to a dangerous rise in body temperature. And, most characteristically, mad as a hatter.
This is the central effect. The M1 blockade in the brain causes confusion, delirium, bizarre behavior, and vivid hallucinations.
Precisely. Now, toxicity isn't always a dramatic overdose. Sometimes it's just giving a standard dose of an anticholinergic drug to the wrong patient.
The contraindications. Who should never, ever take atropine or a similar drug?
There are two big groups you have to worry about. First, patients with glaucoma. Specifically, those with narrow angle or angle closure glaucoma.
Because if you give a drug that dilates the pupil, the iris tissue bunches up in the corner of the eye where the drain is.
And you can physically block the drain. You obstruct the canal of Schlemm. Aqueous humor can't get out. The pressure inside the eye spikes, and you can cause irreversible optic nerve damage and blindness in a matter of hours.
It's a medical emergency you caused with a drug.
Right. And the second big group.
Older men with BPH, benign prostatic hyperplasia, an enlarged prostate.
If you have an enlarged prostate, you already have trouble peeing because the urethra is being physically squeezed. You have an obstruction.
And if you give an anti-muscarinic drug, you relax the bladder wall, the detrusor muscle. So now you have a blockage and a weak pump.
It's a recipe for disaster. It leads to acute urinary retention. The patient physically cannot urinate. It's incredibly painful and can cause kidney damage if it's not treated quickly.
So, if an elderly man comes into the pharmacy with a cold and wants an over-the-counter cold medicine, many of which are antihistamines with strong anticholinergic side effects. You need to be really, really careful.
Extremely careful. You could be the one who puts him into retention and sends him to the emergency room needing a catheter.
Okay, we have covered a massive amount of ground here, from the molecular snake of the receptor to the survival horror of nerve gas. Let's bring it all in for a landing.
Let's synthesize this. We started with the idea of the mixing board.
Right. Pharmacology isn't just on or off. It's about which receptor subtype, M1 through M5. It's about where that receptor is located, in the brain versus the bladder. And it's about the context of the tissue, a healthy vessel versus a damaged vessel.
And I really want listeners to reframe how they think about the term side effects.
Oh, this is a good point. A very important one.
When you take oxybutynin for your overactive bladder and your mouth gets dry, that isn't a mistake. That isn't the drug malfunctioning.
No, it's the drug working perfectly, just in the wrong place.
Exactly. The M3 receptor in your salivary gland is, for that drug, identical to the M3 receptor in your bladder. The drug can't tell the difference in location. A side effect is usually just a therapeutic effect in an unintended organ.
Which is the perfect setup for our final provocative thought. Is there a way out of this trap? Are we stuck forever with these dirty, non-selective drugs?
This is where the future of pharmacology lies. And it brings us back to something we mentioned at the very beginning. Remember we talked about the vestibule, the outer part of the receptor that actually is different between the subtypes?
The allosteric site.
Right now, we are mostly using orthosteric drugs keys that fit the main conserved lock. And because the main locks are all the same, we get side effects. The future is allosteric modulators.
So drugs that don't try to turn the main key, but
Yeah.
maybe they grease the hinges.
Or gum up the hinges.
Yeah.
Exactly. We call them positive or negative allosteric modulators, PAMs and names. Imagine if we could design a drug that binds only to the unique vestibule of the M1 receptor.
You could potentially boost cognitive function in Alzheimer's or schizophrenia.
Without touching the M2 receptors in the heart or the M3 receptors in the gut and bladder, you could achieve true subtype selectivity.
We'd be moving from using a pharmacological sledgehammer to using a scalpel.
That is the hope. That is where a huge amount of research is going. It's the holy grail of muscarinic pharmacology.
That is genuinely exciting. Okay, listeners, we have given you the map. We've shown you the landmarks, but you have to walk the territory.
Please, open Goodman and Gilman, Chapter 9. Look at the diagrams of the receptor lid and the binding pocket. Look at the chemical structures of the quaternary amines. See that positive charge for yourself?
And open Katsung, Chapter 7 and 8, and memorize those dose-response hierarchy tables. See the patterns.
Use this conversation as your scaffold, but you have to build the building yourself by reading.
Thanks for diving deep with us.
Until next time.